Basically, mine is a very small talk of probably 5 minutes on the tips and tricks of using navigation. I mean, you heard so far that navigation can be used, to direct a pedicle screw and to plan and execute a safe pedicle screw insertion, wherever it may be. In case of complex deformity, it helps us to plan an outside-in technique of screw placement. You can use pre-registered screws also, but basically in our center, very rarely we use the navigation to track, to formulate our trajectory, but then we use our screws mainly freehand. Navigation then moved after the insertion of planning and executing a screw. It could be also safely used in MIS, and most importantly, it can be used in planning and execution of a tumor resection, however small it may be, as in a situation like an osteoblast or quite a big tumor. To know the exact location of the tumor, you can identify the tumor, and you can use navigation to plan and execute your tumor per se. We have been using navigation also to plan an osteotomy, to be sure that you have excised uh, the adequate amount of wedge for you to achieve adequate correction. It can also be used, technology is now being available to plan your lordosis of the screw intraoperatively by using various systems. But however, navigation with an error is much more dangerous than a non-navigated surgery. We have to remember that. Therefore, there are various tips and trips which we need to follow while you are doing a navigation surgery. It could be divided into 4 regions: the tips after exposure and fixation of the DRA, tips during registration and accuracy check, tips to prevent motion artifact, and tips to maintain the accuracy during the procedure. It's important that you should have all access to all type of attachments to the navigation devices, the registration devices, and it's important that you have all of them as a part of an armamentarium. Uh, Therefore, after exposure, the first part is the fixation of the DRA, or the refraction array. The plan is you have to always assess the steps when navigation will be needed and when it is not needed. Adequate wide exposure is necessary if you are planning to do an open surgery, so that there is a space for you to fix the DRA. And it varies between open and MIS. MIS also is necessary that you are fixed in a part where it is relatively stable. And you have to, usually it's fixed on the spinous process, which is a relatively more stable part. But you can have problems if you are doing it in a child, or sometimes in a revision surgery where you may not be able to fix it to the spinous process. As you can see, it's also important that there is no blood stains over the reflectors. And if there is a blood stains, your image might be quite good. It's very, very important to have a stable fixation of the DRA, or the minimally invasive reflective array. Either it could be on the spinous process, or if you are doing a MIS procedure or a lumbar fusion, you can also use it over the iliac crest. People are used fixing the mirror over the Mayfield clamp, which is not advocated by the company, is then out of usage, but still we have used it sometimes, found it to be quite adequate. If you have in a revision surgery, what happens is the fact that if you're doing an extensive revision surgery, you find that there is no spinous process left. You have done a fusion in a scoliosis or adult scoliosis where you need to do the revision. What you can do is you can use 2 of the previous screws and put a rod and attach the mirror over the rod, so that you can use that as a firm fixation point. You can navigate all around. You can introduce your screws, plan your osteotomies quite adequately, or in this case, a tumor that has recurred after 5 years and which needed a proper planning for removal of the tumor. Where to fix the mirror? The question is, you can fix it in the end if provided your incision is quite shorter. But if you are doing it for a long segment, it's always better to fix it in the center, so that it doesn't interfere with the fixation of your screws proximally and distally. Otherwise, you need to re-register many times. Therefore, you have to plan exactly depending on the length of your incision when you're doing open surgery as to where you need to fix your mirror. Tip during registration and accuracy check. During scanning, it's better that the patient is in a non-ventilation mode to avoid artifacts. And post-scanning is always better to keep the tidal volume at the minimum possible. You always do accuracy check at multiple known landmarks. Some initially it could be near the mirror, and also see the maximum extent where you are exposed, and you can check your accuracy check. What I mean to say that if you place your pointer over the spinous process, a known anatomical landmark, you have to be sure that that's what is reflected on the screen. As you can see, this is how it is shown. You place your pointer on the tip of the spinous processor and here, and that is displayed properly on the screen. It is also important to periodically check your accuracy, especially if you are doing a long segment fixations. And how to prevent motion related inaccuracies. One of the biggest problems is when you are doing a manual tapping and screw insertion. There is a wobble effect which can cause inaccuracies while you are passing your screws. Therefore, it's always better to use powered instruments like burr and drills to make your pilot hole. And what we usually do nowadays to prevent the inaccuracy is the fact is that especially those screws which are near the fixation of the mirror, what we usually do is we create the pilot holes, and we plan to put the screws only at the later part of the surgery so that the screw insertion will not cause any inaccuracy in the other areas where you are planning your screws. It's important to maintain the line of sight all the time. And you can understand that by this is the UV reader where you can adjust it in different direction if your line of sight is not okay. It's also important that any alteration in the DRA can result in inaccuracy. Therefore, the surgical team, all the members should be aware of it. If you have a new member joining you during the particular procedure, sometimes when they're moving the instruments or they're handing over the instruments, they can move the instrument. And if you think like that, if you are sure that it is moved and there is an inaccuracy, it's better to re-register. And when in doubt, always check with the fluoroscopy. See, this is a scenario wherein you are placing it over the lamina and you find that the tip is just underneath the lamina. That means to say the registration has been lost, there is a movement, and this is inaccurate. Therefore, ideally, when you are placing over here, you should see like that. When you're placing over the lamina, the tip should be seen on the lamina. But if you find the tip to be inside, even underneath the lamina, you find there is some sort of inaccuracy, and you have to be careful. And this happens quite often whenever there is a mobile segment, sometimes in the cervical spine, sometimes when your assistant might touch the instrument. Therefore, it's always better when you're doing a long segment to re-verify it every now and then. Therefore, to conclude, when in doubt, always check with the image intensifier, verify, use it often. The team becomes comfortable over a period of time and it's actually very, very easy. And especially for those who have done an open procedure for quite long time, when you know the anatomical landmark of your entry of your pedicle screw, using a navigation just makes it a subcortical level and takes off the stress of the surgeon. It makes your surgery much more pleasurable, as Bharat said. It helps you to do something which you are hesitant to do. And it's important that advances in technology is ongoing. I know it's expensive, but it's important for us to adopt soon so that we become proficient in the usage of the technology. Thank you.